Hello, this is Jason Wilson, coming to you from Tampa, Florida, at Tampa General Hospital and the University of South Florida Emergency Medicine Residency Program. I'm going to spend some time talking to you about our experience with an HIV screening and linkage program we run through the emergency department, and specifically a phenomenon we've noticed over the past 4.5 years of trying to fit a algorithm really meant for outpatient screening of patients into the box of acute care medicine, and some of the difficulties that we've had with that, and specifically the difficulty that in the emergency department during an acute encounter, we are sometimes faced with a laboratory signature of a patient that's hard to distinguish what the clinical relevance is in that patient between them being a false positive HIV reactive test or a patient who could be much more sick and higher risk of transmitting virus to other patients in the phases of acute seroconversion. So we're going to talk through what that laboratory signature looks like and some ways we've thought about discriminating against those two very different patient populations, and some thoughts about moving forward, how this can be easier for us as we think about redesigning algorithms and moving forward and scaling up emergency department-based HIV screening and linkage. Presenting this along with Heather Henderson, who runs our social medicine programs in Tampa General Hospital, and Kaitlyn Pereira, a fourth-year medical student who's going into emergency medicine, who's been instrumental in helping us think about this work and some of the study design as well as doing a lot of the data work. So thanks a lot to Kaitlyn. So I sort of mentioned that one of the issues is that when we scale up HIV linkage, we've noticed that we oftentimes are faced with this really clinically useless laboratory signature, having a patient with antibody antigen screening test that's reactive, but then having an antibody test for HIV that's negative. And of course, right now, the next step would be to get a viral load through a PCR RNA test, but those take 2 to 3 days at our site to come back. So they're not very meaningful during the acute clinical encounter. So what do you do with that patient in front of you that has a reactive antibody antigen screening test? In other words, there's some reason why the P24 antigen is popping, or they actually have HIV-1 or 2 antibody. But then you go into the specific test, the antibody test, and it's negative. They could be in that phase of positivity where their antibody just hasn't mounted yet, or they could have just had P24 antigen showing reactivity for another reason. And how do we distinguish between those two patients, and what do we do with that information during the clinical encounter? So again, equivocal is what we're looking at patients with equivocal test result, and we're defining an equivocal test as either an acute positive, that's where the viral load is eventually detectable, or a false positive, that's where the viral load is not detectable. But during the acute clinical encounter, this first part looks the same. For some reason, the HIV antibody antigen screen is reactive, but the antibody is negative. So again, the problem is that the RNA test takes too long to come back. I would offer that in the year 2020, when we do PCR testing for virtually everything else, as we try to fit an algorithm into an emergency department setting, this may be something that just doesn't fit well or is a little bit behind where we're currently at with technology. We obviously, most of us are dealing with COVID and SARS-CoV-2, and that's a PCR test was developed very rapidly. We've had an influenza PCR test for a long time, the GI pathogen panel, the respiratory viral panel, but we don't have a rapid HIV PCR test. This also goes to the question of screening versus testing. And as we move forward, we might want to start thinking about different algorithms in the acute care setting as to whether we're screening the patient or are we testing the patient for HIV. I would offer that if we're testing the patient for HIV, the standard for testing emergency department for viruses seems to be floating around the idea of using PCRs. But we are where we are, so what do we do in the absence of a rapid HIV PCR? The question on the table here is you've got this patient who's got the antibody antigen reactivity, but an antibody that's negative. Is there something else we can look at to try to figure out if this patient's likely to be HIV positive or to be a eventual false positive patient? So we'll talk about how often this happens and what we think about the clinical characteristics of those patients over the last 4 years of our experience. So we implemented an HIV screening program in our emergency department back in May 2016. We do quite a high volume of HIV screening. About 22% of the overall patient population that enters our ER between the ages of 13 and 65 do get an HIV test. So that's been about 55,000 patients between May 2016 and May 2020. So that's about 1,100 patients a month on the Architect platform. And the question is, of those patients, if we get this equivocal designation, what do we do with them? So 55,000 patients tested over that time frame. About 787 of those patients had the result that we're talking about. Most of the patients are, of course, negative, but then 787 patients had a reactive HIV antibody screen. Of those patients, we can clump some of those into either a chronic positive or subacute positive. They're positive long enough that the antibody is reactive, and so they're not too concerning. We can move on with linking those 668 patients. These 99 leftover patients over the past 4 years have been the difficult patients. These are the ones that we have struggled to really know what to do with during the clinical encounter. So of those 99 patients, what we learned was that ultimately, probably 3 days after the ED clinical encounter, about 26 of them were actually acute positives. And those acute positives are the ones we are most concerned with. But 73 of them went on to be really just false positives. They had some other reason why the P24 antigen had reacted positive to begin with. So looking at some clinical characteristics of these patients, we'll see that statistically, more of them were male, they were younger, they were less likely to be married, they were more likely to be men who had sex with men. They were like, one of them had one of the ones who were acute positives had an HIV positive partner. They were more likely to have multiple sexual partners, unprotected sexual encounters, not statistically significant because of small sample size, but 2 of the patients in the acutely seroconverting group were IV drug users. None of the ones in the false positive group were IV drug users. Really no difference in hepatitis C status or difference in previous sexually transmitted infections. There were 3 homeless patients in the acute positives group, only 1 in the false positive, right at the 0.05 and some change levels, not quite statistically significant there. 1 of the patients was currently incarcerated who was an acute positive, and really no difference in alcohol use at presence between the 2 groups. So in total, again, we have 26 what we call acute positives, meaning HIV antibody antigen screen is reactive, antibody is negative, however, the RNA is positive. 73 false positives, meaning HIV antibody antigen screen is reactive, antibody is negative, and then the RNA is also negative. So overall, this is not a negligible number of patients. Of the positives we've had, of the HIV antibody antigen screens that are reactive positive, 99 out of 787 were equivocal, meaning the antibody was not detected. This makes it so that a provider doesn't deal with HIV all the time, and the emergency department is faced with a dilemma about 12% of the time when they have a positive result. They really don't know what to tell the patient. I would offer that it's hard to scale up a process where 12% of the time you're not sure how to interpret the diagnostic test in front of you. So I think this is one of the limitations of scaling up HIV testing across other emergency departments and community settings, other places where people don't routinely think about or deal with these sort of issues about the current technology and the algorithm around HIV testing. Again, of course, a rapid RNA or PCR viral load turnaround time would help with this. But in the meantime, can we think about some of these clinical characteristics like young age, previous history of men who have sex with men, IV drug use, homelessness, as likely putting us towards the presumption that this patient is a true positive and initiating that linkage to care pathway as quickly as possible. I'd like to thank the Focus program as our disclosure for providing funding for the linkage work that we do, and the references are here. Again, I'm Jason Wilson at Tampa General Hospital, jwilson2 at usf.edu if there are any questions. Thanks a lot for your time.